Okay, guys. Good morning. How you guys doing?
Good morning.
Everyone's
Good
okay?
morning.
Yeah. So, like I said early, this is just for you guys to ask questions because most of you guys got like two or three different instructors. Everyone got different questions. So I want you to ask anything you guys can think about it about just hospital related, COVID-19, anything that you guys learn from the other people. Maybe I can explain different way, but at the same time, every single RT practice one way, every single hospital practice a different way. That makes sense? All right, you guys got any questions?
I do.
All right, so you can put in the chat or you can put it straight. It's up to you guys. I don't mind.
How are you guys doing with cold blues? Because Alexis from TGH, she explained that before, and they do any compressions, they put a mask on the patient. Is Lakeland doing the same thing?
Yeah. So that's a I wouldn't say an issue, but we have a new protocol called Code Blues or Code 99. That's what we call it at work. So yes, so they require only one RT, one nurse, and actually two nurses and a doctor and a pharmacy should be outside to hold extra medication as needed. The code card do not go inside the room. What our job as RT set up everything. So every single code card now have a specific box. That specific box has a N95, three N95s, have three surgery masks, and have like a protective gear that go in the front. Okay. So all that being said, that's a job for the RT. Now specific code 99 or code blue, we not doing compression. It's only two nurses in charge of compression. And yes, we put a mask on top. The biggest issue we have is we're not allowed to bag. So bagging is a no. So we put a non-rebreathable. But Angela, if you have to put a non-rebreathable, what's the issue when you put a so patient is coding and you put a non-rebreathable?
Is the droplets coming out?
Okay, that can be one. Not really, but what's the biggest issue? The patient is got he's a code, flat line. You guys learn EKGs. That's flat line. So what is that? What does that mean? If you put a non-rebreathable in someone's face, what is that doing that
Is that
non-rebreathable?
enough oxygen?
It's not providing oxygen.
Is that enough
It's
oxygen
not.
for the patient?
It's not doing nothing because the
No.
patient is not
Yeah.
taking a breath.
Right.
So it's like just might as well put a number put in the floor. That makes sense. So you see what I mean? So that's the issue we have. It's like so what we do, we just don't do nothing. We cannot back. You know what I mean? EMS pool, LMA or iGel. You guys know those two. So that's another issue. LMA, iGel doesn't get real close seal. It's not closed circuit. So when we back on day back, they throw in the virus everywhere if a patient is infected. So yeah, it is sad, but Code Blue, Code 99 changed a lot. We have a protocol that protects us, but some RTs is still bagging. And if you bag, they recommend only about 250 to 500 cc's. So that's pretty much you not even pressing the whole bag. You're like, that makes sense. Just a little bag. So they're trying to do RSI, like I explained last time, rapid sequence intubation, and this hope everything okay. But you guys know, I think it's 6 minutes to a brain injury.
Mm-hmm.
So if you think about it, from the point they found the patient, how long more the patient was down. So you say you found it at 9:45, but the patient was down 9:10, and we're not bagging. It is sad, but it is what it is. As long you guys keep yourself safe too. All right. Another questions?
So you're saying your patients can have brain damage because you guys are just taking longer than.
Yes, because the brain doesn't get oxygen. So for
Yeah.
example, for oxygen, you need two things. You need one is circulation. That's due to the heart. That's the reason we do CPR. And also the patient need oxygen. I mean, the most important thing is circulation, but then you start bagging. So if you start doing CPR and then you start bagging, some oxygen can go back, accumulate back into the system, go to the lungs, go to the circulatory system, take it to the brain. That makes sense. But in this point, we're doing CPR. Well, we're not bagging, so definitely oxygen is a big oxygen issue. So I think it's 6 minutes that your oxygen can run out of. I mean, your brain can run out of oxygen, and you pretty much can become brain dead.
Are you having? Do you guys have any patients that are brain dead because of the way codes are run now?
Uh,
I know it's a HIPAA violation, but I'm just yes. No.
yeah, we not working the coast that much, put it that way. So that's a big issue too. Like in the ER, we run it maybe for 5 minutes, they see it and they call it out. So everyone that come with respiratory issue is a virus alert. So it's a big issue. So yeah, so the code doesn't get work a lot. So yes, most of them they don't even make it. Anything else? You can put a question in your chat too if you guys want to. Any other question? Anything that you guys can think about COVID-19? Anyone you guys think about? I know Jody, you
I
found out.
do.
Did you
Yeah,
find out why you're a patient?
I wanted to know about what your protocols for testing are, are for your hospital.
So there's like okay, there's different tests about in our hospital right now. One is still doing the swab. So pretty
Mhm.
much that's the molecular test. That's the one that they send it to the lab. So I just found out that, for example, when we do the swab, you're supposed to do it for 12 seconds in your nostril. So literally, you're in the sinus. You're supposed to be in the sinus, cow, do the swab. Then it take wherever the lab is located. I know we should have a lab in Tampa, so we take it to, I'm not sure, to or what is it called, Bay Care in Tampa, Tampa General. So pretty much we take the sample to there, and from there to take 2 to 3 days to do it, up to 7 days at one point. But right now we do it faster. We I'm not sure we have a 5 minute test, but we definitely have a sputum test. So they're checking for antigens. So once a patient get intubated, we do a normal sample, pretty much a mucus sample or so we just suction the patient, the inline suctioning, and we get a sample and send it to our lab. And our lab will be able to tell yes or no. So we have those two type of tests. Uh, Once you have the swab and you take it to a lab, it just take like 5 to 10 minutes. But they got so many tests, and the transport take too long.
Right.
I read something too where I guess there's been a problem where they're not, a lot of times the practitioners that are doing the ones like the drive-by testing, they're not getting far enough up and back. They're getting the wrong part of the endo
Specimen.
and
Yeah, so that's a big issue too, because I'm not blaming the nurses or anything, but they just go like this.
yeah.
I mean, you're supposed to go like up here for 12 seconds, and some people bleed. I'm not saying they should make him bleed, but it's supposed to go there. So that can be a negative. So most say, oh, most of the sample are negative because of blah, blah, blah. No, they're negative because they're not doing the right swab. So you remember it was a 50-50 chance. Another thing, you can be negative today, but tomorrow or the other day you can be positive. So that's the biggest issue we have. It's not when you become positive. You see what I mean? Because you can have live flu symptoms, everything, or can be just allergies. But then you do the test today, but tomorrow, next day, you can be positive. So it's a dangerous zone. All right. So now you guys talk about tests. So we want to do a couple things. Okay. So we have the swab. I'll tell you that's called molecular test, and that can take up to 2 to 7 days, depends the lab. Now we have more labs open and more tests available, so it's faster. Okay. The biggest issue we have is like most of the people they have the antigens to test it, the results. So that being said, like okay, so we have all these labs ready to work, but we don't have the antigens, so we cannot go nowhere. Another test is called the serologic test. So the serologic test, you guys kind of know something about it? Anybody?
It's a blood test.
It's a blood test, literally. So, oh, you guys, how you guys know how we check the flu? how we check the flu, or how we check the sugar.
Mhm.
Okay,
Will they,
so
will they test the serum?
yeah, so pretty much the serological test has to do everything with fluids. Now they can be how much they can be urine, they can be blood. I think more specific is on blood, but it's another test. I can do urine, blood, saliva, sweat, serum. That's the reason they're swapping also inside your mouth too to check for any type of virus. So they can do both of the tests at the same time. So what they do pretty much they get a sample of blood, they take it to the lab. But now that we know more and more and more, it's almost like the flu. How many of you guys ever went to the doctor, they swab you for the flu, and we said you want to wait for the results, or we call you because it would take 2 to 3 hours or 4 hours? You see what I mean? So it's the same thing with this kind of test. They can do that. They can take a blood work, or they can do a big swab, and they can do the same test, do the serologic. So with that test, it became better, better, better because there's a machine right now that China created, and they're using it right now in Italy. So what it does, you can get three drop of blood, you put into the machine, and in literally almost, it's almost like an ABG machine. It's to give you the result right away. So you can know two, three things. If you got if you have a virus, if you ever been exposed, or you have already antibodies with the test. So that's what we really need. We really want to open back our economy. That's what we need in this place, because like that we can tell, we can test you right away. We just drop blood from you, we test, make sure you have the virus, how long you have it, and if you have antibodies. So that will help us a lot to know who's contagious or not, or who has been exposed in the past. I mean, I believe most of the nurses, RTs got exposed at one point, but because we see too much things in the hospital, possibly we got better. All right, what else?
Can you explain a little bit more when you said someone could be test negative but then positive, like, or when someone has the virus and then they get retested, they're positive again? Like, I know someone that they got the virus and they start feeling better, and
Yeah,
after 14 days they got retested again and then they were still positive. That means like they still have the virus, or I quite
yeah. So this is what they're saying. Like you can be contagious for 5 to 14 days. Okay, so you cannot you got the virus just on the first. Just give example the first. So the first 5 days, 4 to 5 days, up to 7 days, you can be asymptomatic. You can get sick, and then you can be start spraying the virus without feeling no symptoms, no fever, no diarrhea, you don't lose your smell, your taste, anything like that. So then you'll be able to spread the virus to a lot of people. But then your body's strong enough that it create antibodies and can contain the virus in your body. But in those 5 to 10 days, you can spread the virus to many, many people. So possible, I'm not sure your friend case, but it can be that she got exposed to somebody. She was okay. She got sick for 2 3 days. Her immune system was good, created virus, created antibodies, and she got better. But when she did the test 14 days later, that means she got the virus, but her immune system was fighting it back. That
well,
makes sense.
she got tested twice and both times she was positive.
Okay, so the way you to come out of the test if you test twice negative. So if she was positive, her body got better. 14 days, she still have the virus because you have to fight it. They say it takes 2 to 3 weeks approximation to get antibodies, and then after that, take another week to be able to be not get sick again. That's just what they say. But look what happened in South Korea. People are having the virus again. So we're not sure if they never got better 100%, or they just a second wave for the same virus. So that's what we don't know. But so your friend got exposed, you say at the 5th day she was sick, she was positive, 14 days she got still the virus. She has to wait another week to 2 weeks to do the test again. But she has to be negative 2 consecutive days to see she's not dangerous no more. She's not be able to expose no more. That makes sense?
Yes, thank you.
All right, so they are saying they don't know how long immunity will last as well if you are found to be immune. Yes, that's what they said. Like because in South Korea, supposed to have a second wave. So I hope whoever get the antibodies be able to help other people, but at the same time be able to protect yourself more. All right. Any other questions? Anything? Anything? All right, so the 5 minutes test that people are doing right now, this is, I mean, I think Alicia says 70% effective. That's about true, but remember, it's all about the technique, how far go in the sinus, and that's when the 70% come. We're doing by Experian right now. Everyone that get intubated, they get Experian sample right away, and they checking for antigens in there. Um, the molecular test is they do with PCR, so that is self-explanatory. The serological can do by blood work. That's a more effective one because you can show IgMs, IgGs. So they say if you have the IgM, that's mean you recently be exposed. So that's how they check. If you have IgGs or the G, that's mean you've been exposed for a while. That's mean you have great antibodies, but we don't know you can take a test again. They have lateral flow, and they say with lateral flow, pretty much I think they do in Germany, and that's where you can get the urine, the blood, saliva, all those kind of tests. I believe South Korea implement that one too. The replicating antigens can take it 2 to 5 hours, but like I said again, it depends how many antigens they have available to do the test. All right, so another concern we have in our hospital is the MDIs. For sure, Alicia went about MDIs. So we definitely have short MDIs. What we supposed to use what we supposed to use every time we use an MDI?
Spacer.
Spacer. So you got know the spacer have a one-way valve. Pretty much you can take it in, but you're not supposed to blow it out because nothing go back. All right. Because of that, the same patients can use the same canister. I mean, we can use the same canister in different patients. So we have approved by our manager, I'm not manager, but our COPD evaluator guy that we can use the same canister in different patients. We got approved by infection control. We got approved by the pharmacy. So now if Jody comes to the hospital, I can give you the MDI with a spacer, and then they say I give you 4 puff. I have to take the MDI back, take it apart, clean it up with a super cleaning virus thing, whatever that we use it right now. Leave it for 5 minutes, let it dry by air, and then Angela come back 20 minutes later. I can use the same canister and give it to Angela because we're short MDIs.
Dio, have they been using like the ovens?
So we don't have an oven, but we order a UV lights. So it's like I'm not sure you guys see new commercials about UV lights. It's a little box you can put your cell phone, it kill everything. So yes, I heard the UV light is effective. So we order I think 5 of those, but it's coming like in May or something. So we're a while. So what we want to do, we want to have 5 of those in different places. We want to put the MDI in that UV light, and they told us to put our cell phone too. So 5 minutes and you get disinfected. So that's what we're using now. Okay. That's what.
Sorry, at St. Joe South, they were doing common canister before all this started.
We supposed to do it, but with no one agreeing in our hospital, we were still debating, so we never really agree on it. It was a bad thing, but then now it's mandatory. If you take too many, they can you can get in trouble saying that you took it home or something like that, or you forget medication at the room. So yeah, so we are more precautious about it. I mean, some people are real rough, and you have to share the canister, so it is what it is. Okay. You guys hear about negative pressure rooms?
Yes.
All right. So you guys got any idea how that work?
It sucks it out.
It goes through a filter and up through the roof, correct? Like a duct system.
Mm-hmm. All right. So pretty much what it does is like, like you have your AC in the house. If you guys look in every single room, you have the AC that give you the air pushing through you. In a in a negative pressure room, it's the opposite. You have that one, but at the same time, you have there is, I mean, you guys supposed to change the filter in your AC. You guys know where you change your filter? You guys put your hand there. That's where the air pretty much suck it in. So there's two ways. In the ceiling, the air coming out. In that return, the air go back to the AC. That makes sense? So going back to the condenser, pretty much it bring cold air. So it's a circulation. In a negative pressure room, you want to be whatever suck the air back out from the room is stronger than the supply. Like that, you have a negative pressure room. So instead to anything come out from the door, you'll be able to feel everything suck it in and be able to pass through HEPA filters, and the HEPA filters help it to clean. Supposed to uh, catch all the virus in there, any particle, anything. So that's how they do in the big coliseums, in the big stadiums, like where they're having patients with COVID-19. What they do, they just pull a big machine that throw the air out from the tank. So if you see like they make a bunch of hospitals in New York Park, Central Park. So they do the tank, they close at night, and they put big machines to suck the air from inside to outside. So that's how you create a negative pressure. So before we go outside, has to pass through HEPA filters. Many hospitals, what they did, they reverse the system instead of the air outside and the air coming out from the ceiling, suck it in. So it created a negative pressure, hoping that pass through HEPA filters and it became everything, all the particles that go through there became a negative pressure room. Uh, it's not an easy test to do. I mean, you can reverse AC in one part of the AC, but at the same time, some hospitals are too old that we don't have control valve to we can say, hey, let's do every hospital the same way. But like I think TGH they doing it, couple floors they do everything negative. So what they're doing, they're reversing the AC literally. Instead to blow it out, they suck it in, so everything become negative pressure, and the pressure has to be the pressure in the hallway has to be higher than the pressure inside the room. That's how it become a negative pressure room. That's all they can do right now. Anything else? Nothing. I'll tell you two questions. That was today. All right. So I just want you to guys. I know you guys got too much homework, too much things to do, and that's what we're doing right now. I know both of you guys got a lot of tests to go on, everything. So we just want you to just whatever you got from this presentation, real quick. On Wednesday, like at 10, I will have my next one, and that one I want to go to another patient case, pretty much. Um, how different work. This is a little bit different, but I want to do more homework. I want to do the CT again. I got like one picture of CT. I got a picture that I got it from Gina. Um, I got some ABGs for that patient and some bands. The hardest part for you guys is like you guys not doing band yet, so is we can do more and more work with no ventilator a little bit more, but eventually that will come out later. So when you guys do this presentation today, I want you to guys to put a couple of things. One, the biggest thing I want you guys to do is um, write down what you guys do before you go to a patient room, because most of you guys, I bet you forgot what happened. You know what I mean? Because we was doing good. We was doing every day, and became a habit that you didn't even think about it. So go step by step. What we do before we go to a patient room. All right. When you're in the patient room, medications. Why you give your bureau? I mean, like, what is a bureau? What is Atrovan, Brabant, and Pulmicor? Just like you explain to the patient. Make it simple. A bureau is a bronchodilator helping to open your airways. Something simple, like you would tell the patient, Atrovan, don't you know to say it's a llama? Oh, that's helping with a bureau to open your airways. Okay. What is Brovana? It's a long acting. This will help you, and they will give you every 12 hours. What is Pulmicor? It's a corticosteroid, and this will help you with inflammation. But that you guys keep in mind what we're doing, because if you guys can put the dosage even better, like that, you guys keep in track. Most of you guys, I bet you they forget the dosage of bureau. What's the dosage for a bureau?
2.5 milligrams.
Okay, so make sure you pull milligrams because that's kind of important. So once you do that part, just do in the bottom, just pull what we're looking every time we look at patient chart. Whatever you guys can think about, CBC, UA, just don't be specific. Just put names, everything like that. When you guys go back to the hospital, at least you guys remember what you're supposed to do when you go back to the hospital. Okay. On Wednesday, when I give you my patient, I want you to do a soap. All right, soap is important to us. So I'm going to tell you pretty much everything for the soap. You guys to plug it in. All right. Remember how we give a little history of my patient, and then you guys that will be for next Wednesday. So this part, just do your line. Hey, hi. Um, okay, so check power orders, check blah, blah, blah. Hi, I'm the respiratory therapist. I'm here to give a breathing treatment. And then you explain. Just think about it when you was in the hospital, when you go to a patient room, what you did. Like that, you guys keep in track. I know you guys got a lot of homework, but this will help you out to keep in track because you guys not practicing. And that's a bad thing. So when you got back to the hospital, at least you have your line. People learn by one, visualizing, listening, and writing. Okay. I learned by listening. Some people do different ways. So just keep yourself in track. And that's pretty much it for today. Unless you guys got any other questions, I don't got nothing for you guys. Like I said, I got my other things, but that's coming on Wednesday. Wednesday going to be a little bit longer, maybe an hour and a half. Yeah.
Dio, for our assignment, we're just doing those things and not the summary, correct?
Say that again.
So for our assignment for this video, it's just what you want us to do, not the 3 things we learned.
Yeah,
Okay.
no, just whatever you guys listen to me early about the tests, different kind of tests we have, the MDIs and negative pressure. You guys want to write those things down, just how that work, everything. But the most important thing that I wanted to go today is like think about it when you was to a room,
Okay.
room. That's like the main thing for me today, because like that you guys keep practicing. Like for example, what you do, check first of all, check power, get report. You mean things like that. Small details sometimes make a big difference because think about it. I went to a room, I clocked in, I did report, things like that. Then went to the computer, check power orders, check the MAR. That's for our group. I don't know where you guys see it, but at least you guys keep practicing. I check my MAR, medication was blah, 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 blah. I'll give you already 4 medications like that. So like that you guys can know. And just keep it simple. And then after that, I went to see my patient, knock, knock. Hey, hi, I'm Jody, respiratory therapist. I'm here to give you a breathing treatment. I'm going to give you a bureau, battery, blah, blah, blah. All right. And then I say, then what's the first thing you're going to ask a patient?
Name and date of birth.
Name and date of birth. You see, like that, you keep in sequence. So try to think about what you was doing every day in the hospital. Because some of you guys got it like right away. Some of you guys took time to develop the skill. And now most of you guys got a little skill there, or got better, and then boom, you guys lose it because you guys didn't practice. Send me. So hey, what's your name and day of birth? Blue. Okay, let me listen to your breath sounds. Just make up some breath sounds. I don't know. Heart rate 102, rest rate. You send me so that you guys keep in track, because that's the thing that we do. So then you listen to your lungs, set up the treatment, put in airflow meter, 5 liters, putting aero clips, things like that. Try to think about it what you did step by step. You know what I mean? Then you can put eye chart, listen to patient vital signs again. Just make a little history of what you did every time you went to patient room. That's the main concern for me today. Like, make sure you guys doesn't forget, because like I said, some of you guys got it boo, some of you guys got it. I still have to go to a patient room, and then like that. It's not. I know you guys got a lot of assignment, but this will help you to keep in track. That makes sense, guys. Everyone's okay. Agree. Not bad.
Agree, so we can just make our own little scenario for the patient.
Yes, it's just like whatever you did in that, however you do your clinical care, I want you to do the same thing. But keep in mind, because that's what I did when I was a student. I went home, I practiced my line. Hey, I'm the respiratory therapy. Hey, I'm the respiratory therapist. And when somebody says something to me, I'm like, oh man, what should I say now? You see what I mean? So I'm always a guy who's like, hey, good morning. Hey, good morning. Hey, good morning. That makes sense. And then you can, after that, you can say, so after you finish your treatment, where to patient chart, review CBC, review X-ray, review ABGs, whatever you can think about it. I mean, don't put nothing yet, and later on eventually we keep going more and more and more in details. That makes sense. I know you guys got nothing to do all day. Mike, Stanley, Kiona, Sumaira, Mimi, Enrique, Angela, Ariel, Maury. So I know. So that's all, guys. No more questions. That's everything for today. And like I said, you guys okay? I mean, try to be here on Wednesday, because we want to go more into one more patient, so we should be good on that one. Good. Hey, do exercises, guys. Don't be like Mike. All right. Keep you guys healthy.
Thank you.
Thank you.
All right.
Yeah.
Thank
Stay
you.
safe. See you guys on Wednesday. Bye bye.
Okay.
Thank you. Bye. Bye.